Hello, everybody. This is Eric with FlightBridgeED, and this is going to be podcast number 1. We're going to do a 2-part podcast on rapid sequence innovation, and I thought I'd start off and do a short podcast on the pharmacology aspects of RSI, go through each drug in depth so we have a good understanding as it relates to our patients and how they react to it. We're going to start off and basically talk about preparation. The preparation aspect of RSI starts probably 10 minutes before we actually start giving medications, and you're thinking about your dosages, you're thinking about how you want to approach your patients as far as sedation with opioids and then your neuromuscular blocking agents. So we're going to go through each one of these pretty in depth again and talk about how they affect our patients. So the first medication that we come to is lidocaine. And lidocaine, obviously, we've seen lidocaine used in the cardiac arrest situation for arrhythmias, conscious, VTAC with a pulse, etc. But lidocaine also has other uses. And in RSI, it's thought to blunt the rise of ICP that's associated with airway manipulation. So the standard dose for lidocaine in RSI that I've seen is anywhere from 1 to 1.5 milligrams per kilogram, and I tend to stay in the 1 milligram range. I think the math is a little bit easier, so I'll just give 1 milligram per kilogram. And the average dose is 1 box or 100 milligrams. It's really protocol dependent from what I've seen if we're giving lidocaine or not. Most of the time it's up to the clinician if they want to give it, and so I tend to give it in patients that already have a potential ICP problem, head injury, strokes, etc. The next medication we're going to come to that's again up to the clinician in some circumstances is atropine. In most protocols, atropine is used in the adult setting if the heart rate is below 80. I've seen actually some protocols if the heart rate's below 100. And the reason why is anytime we put a laryngoscope blade down the throat, we're compressing on that vagus nerve back there, and we have that parasympathetic effect, and we can have bradycardia. So giving atropine in that setting is usually a good thing. The dose range is anywhere from 0.02 milligrams per kilogram, minimum dose of 0.1 milligrams often, and usually the max dose that I'll give is 0.5 milligram. I don't tend to give any more than that, so that's kind of my stopping point. And then we also give it in all children, any child that's 8 years old or under, because of their large vagal tone that they have, and the potential for bradycardia in these patients, and how bradycardia affects a child. We know that that's a very ominous thing. We don't want to cause a bradycardia in a child. So atropine on all children is a must. And then we start talking about pain management, and this is kind of a new concept as it relates to EMS. I know when I started RSI in patients early on in my career, we never did any type of pain management when it came to RSI, and but over the last, I would say, 7-8 years, fentanyl has been put into the drug mix for RSI, and what they found is RSI is extremely painful. When we put a laryngoscope blade down somebody's throat, we put a tube down there, it's extremely painful. And so the whole point of that is to block any sympathetic tone. And, we want to make them comfortable. So the standard dose is going to be 3 micrograms per kilogram. So that's a big dose. Average patient, if you look at a 80 kilogram patient, that's a 240 microgram dose. Remember, fentanyl is extremely stable on blood pressure. It does have a little bit of a histamine release, so you can have a little bit of vasodilation, but for the most part, it's extremely stable. It's an excellent pain medication, and I tend to use it more than anything. I don't think I ever pull morphine out anymore. because fentanyl is such a great drug. So the fentanyl may decrease your tachycardia. It may help if there's any hypertension. It just may drop the pressure a little bit, but again, it's extremely stable. So if you have a patient that's a little bit hypotensive, maybe cut back your dose a little bit. You don't have to give the 3 micrograms per kilogram, but you definitely want to give some type of opioid dose and get them nice and comfortable prior to intubation. The other thing with fentanyl is it's got some sedative effects in higher doses like that. So the 3 microgram per kilogram dose has that analgesic effect, but it also has a sedative effect. So it's kind of a double whammy there. So from that point, you can use morphine sulfate in these patients as well. A little bit longer acting can blunt some ICP problems if you have a patient with ICP already. It does have a histamine release as well. The dose for morphine in these situations is 0.1 to 0.2 milligrams per kilogram. But remember that this medication can cause a pretty profound vasodilation and can drop your pressure quite a bit. So I tend to not use this medication in an RSI setting, and really, from what I've seen industry-wide, it's not really used. The next medication we want to talk about is what we're going to use for a induction agent sedative-wise. And the most common medication sedative-wise is going to be your etomidate. And etomidate, remember, is a non-barbiturate hypnotic. It's excellent. It decreases ICP. So for those head injury patients, trauma patients, stroke patients, it's an excellent induction agent. It's very rapid onset. It's got a short duration. It's got very minimal hemodynamic effects, so you're not going to see the drop in blood pressure. It does not cause any histamine release. And it does, I believe, have a little bit of effects on seizure threshold, so it decreases seizure threshold. So your standard dose for etomidate is 0.3 milligrams per kilogram, and so what I do is I just take my desired weight that I've determined the patient to be, and I divide that by 3. So a 100 kilogram patient would be 33 milligrams, and then I just round that down to 30 milligrams. And so that's really easy. Always make your math easy. Now remember, when you're estimating weight, it's an estimation, right? It's subjective to what you see and what you feel. We should be trying to do that based off of height as well. What ideal body weight is, and so just remember that make the math easy for you. Don't make it difficult. Other medications that we can use for induction, which I don't really see in many protocols, maybe in the hospital setting, is propofol. So Diprivan, it's a sedative hypnotic as well. It's extremely rapid in its onset, extremely rapid, maybe 10-15 seconds. And it's got a duration of about 10 to 15 minutes. It's very good in decreasing ICP, and however, it can cause some pretty profound hypotension. So we got to be very careful when we use it. So if you had a patient that was extremely hypertensive and you were trying to look for a medication that would drop the pressure a little bit to help you out in that way, propofol would be an excellent medication. The dose range for induction for an IV push would be 1 to 3 milligrams per kilogram, and then you can hang a drip on these patients as well, and that's anywhere from 50 to 200 mics per kilogram per minute in a maintenance dose. The great thing about propofol is that if you have a patient with a head injury or a stroke, that you have propofol hanging for induction and then the maintenance sedation, is once you turn that off, the patient's going to be able to come around. The effects are very short acting again, so the neurosurgeons seem to like it. They can assess their patients rather than if we gave a long acting paralytic in that situation. It could be 30 to 45 minutes before the neurosurgeon is able to assess their patient. So that's something to always think about. Ketamine is another medication. It's an excellent medication, but one thing about ketamine is it's maybe a little bit better for certain situations. So excellent for children, excellent for the asthmatic patient because it has pretty profound bronchodilatory effects. It's very rapid onset. It's short duration as well, and it's also contraindicated in head injury patients because it causes an increase in ICP. That's where you need to really look at what you're given. You need to know your medications. You need to know your how your medications affect your body. It's very important. So, better for children, excellent for the asthmatic patient. It can be used for adults as well. It's got great bronchodilatory effects, the dose range in this medication, I believe, is 1 to 2 milligrams per kilogram. And so, again, excellent medication. All right, so now we need to talk a little bit about, we've given our lidocaine, we've given our atropine, we've talked about our induction agent, metomidate, we've talked about ketamine, we've talked about propofol. So what are we going to give as far as our paralytic? And so let's talk a little bit about paralytics. The two classes of paralytics are either non-depolarizing neuromuscular blockers or depolarizing neuromuscular blockers. The standard induction paralytic that we use is a depolarizing neuromuscular blocker. And so what that means is it basically depolarizes all of the muscle neurons at one time. It's a non-competitive depolarizer. So what happens is acetylcholine fills those muscle neuron gaps, and all that sucks in choline is two acetylcholine molecules. That's what makes up the drug, and so it causes just a rapid influx of acetylcholine into all of these muscle neuron channels. It causes a rapid stimulation of all these, and that's where you get what's called fasciculation. So all of these muscle fibers are firing at one time. So it basically fills everything up so it can't fire anymore. So that's how succinylcholine works. On the other hand, the non-depolarizing neuromuscular blockers are competitive, and so they block the acetylcholine receptors. So they don't allow any acetylcholine to get into that neuromuscular junction, and thus it causes paralysis. So which medication is better? Well, the thing with depolarizing neuromuscular blockers are they're shorter acting, and so oftentimes we use these medications for induction, the medication that's most standardly used for induction is succinylcholine. Succinylcholine is an excellent medication. I've used it many times. It's been the gold standard for a long time. The onset is really quick, 30 to 45 seconds, and it's got a duration anywhere from 5 to 10 minutes. And the standard dosing is anywhere from 1 to 2 milligrams per kilogram, and I think most protocols just go with a 2 milligrams per kilogram dose. And then the max dose, there's really no max dose. Some protocols may say 200 milligrams. That's how much is in one 10 ml vial. From what I've seen and what I do in my practice, that I always just stop at 200 milligrams. There's really no need to go higher than that. So I'll go 200 milligrams max, 2 milligrams per kilogram, and excellent medication. There are some contraindications to succinylcholine and some things you want to watch out for. You can have some, again, muscle fasciculations that can cause vomiting. You can have a potassium shift, and it can cause hyperkalemia. It can cause trismus, where you have a masseter spasm. It's often seen in children. You can have what's called malignant hyperthermia, which is something that isn't a good thing. It's actually a very, very bad thing. When that happens, mortality is up to 60%, and basically it causes a influx of calcium to rush into the neuron cells, and it causes this massive increase in body temperature. Malignant hyperthermia is something that you can't really see. Some patients may know that they're predisposed to this, but it's kind of one of those things that happens, and I've never had it happen or seen it happen myself, but it's a contraindication. The other aspects of succinylcholine, that you don't want to use it for any patients that have had burns within 24 hours or after 24 hours. If you go on scene and you have a burn patient that just was burned, a dose of succinylcholine isn't going to hurt them. It may not be a bad idea to use another paralytic, or maybe stop when you give your sedative hypnotic like etomidate. See if you can intubate them without the paralytic. Might be a better option. Anybody with a penetrating eye injury, obviously we can't use it. So even though it's an excellent medication, it's very short acting. There's quite a few contraindications to it. So that can maybe steer some people away from it. Your next medication that we use paralytic wise is a non-depolarizing neuromuscular blocker, and this medication is used primarily for post-sedation or post-paralysis after you have intubated your patient. There's two medications that fall under that are excellent, that are seen in the EMS realm. The first one being rocuronium, and I had an opportunity to use rocuronium for about a year and really liked it. Actually, we used it in place of succinylcholine, and even though it's what's called an intermediate paralytic, your duration is 30 to 45 minutes. It's an excellent medication. Never had any problems with it. There's really no contraindications to it, so it's very safe to use. Your onset is about 1 to 3 minutes, so it's, your onset maybe is a little bit longer than succinylcholine. One thing that can happen is you can have some tachycardia from it. Your dosing range for rocuronium is 0.6 to 1.2 milligrams per kilogram, and I always tended to go with the 0.6. Again, I'm all about easy math, so what I would do is, if you remember, your etomidate dose is 0.3 milligrams per kilogram. So you already know what your dose is there, and your rocuronium dose is 0.6. So what I would do is I would just double my etomidate dose for my rock dose, and I could do it very quickly. I didn't have to even figure anything out. I just would double my etomidate dose. So that's an excellent way to do that. Your next non-depolarizing neuromuscular blocker is vecuronium, and vecuronium is again kind of the gold standard for post-paralysis management. Your duration of action for this medication is 30 to 60 minutes. It's got an onset of about 1 to 3 minutes as well, so a little bit longer onset. You can have some loss of venous tone, sympathetic blockade. So we'll talk about that here in a second. In a trauma situation that maybe you have a patient that's bleeding out, hemorrhaging, they're a little bit hypotensive, post-sedation or post paralysis, intubation paralysis may not be the best option. Maybe giving fentanyl and Versed, maybe not even giving the succinylcholine when you do your initial intubation. Maybe stopping at the etomidate might be a better option, just so you don't lose all that tone. That might be the only thing that's perfusing, allowing the patient to perfuse, is that body's response to shock and the vasoconstriction and trying to shunt everything. And if we relax everything, it's probably not going to be a good thing. So your dosing for vecuronium, vecuronium is used in two ways. And prior to giving succinylcholine, if we go all the way back to after we give our etomidate and we've given our sedative hypnotic, some protocols call for a defasciculation dose, or defasciculating dose, and basically what it's trying to stop is the fasciculations. So the only way to do that, there's two ways to do that from what I've seen in different protocols. I have worked under one protocol where they called for 1 milligram of succinylcholine. So you're just given 1 milligram of succinylcholine prior to your large dose of succinylcholine, and they felt like a small dose like that kind of stopped the fasciculations. Again, it was the clinician's own decision to do that. It wasn't a mandatory thing. The other way to do it is with vecuronium. Remember, vecuronium is a non-depolarizing neuromuscular blocker. It's competitive, so it blocks the acetylcholine from binding with those muscle neuromuscular junctions in the muscle fibers. So that dose for that is actually going to be a tenth lower than your standard dose. So it's going to be 0.01 milligrams per kilogram. So a 100 kilogram patient, that's going to give you a dose of 0.1 milligrams. And then your dose for your post-sedation or your post-paralysis is going to be 0.1 milligrams per kilogram. So that same patient, that 100 milligram or 100 kilogram patient, is going to get a 10 milligram dose. So you're just giving a tenth of your paralysis dose. Again, I've tried it, I've done it, it works. It's just, to me, it's another step. I've RSI'd hundreds of patients. I've only had one patient vomit back up into my face, which is obviously not a pleasant situation, and it was due to the fasciculations. But most patients, from what I've seen, in my experience, they don't have very profound fasciculations. When we talk about the actual procedure for RSI in podcast number 2, I'll give you some tips and some pointers to try to alleviate gastric distension due to overbagging and things like that. That'll maybe help you so that doesn't happen. And then after we give our vecuronium, if we decide to go that route, we need to talk about post-sedation management. And I'm a big component on maybe not going with our vecuronium in the end. Try to sedate your patients post-intubation with your sedatives and your pain medications like fentanyl and Versed. And so let's talk about that really, really quickly. Again, we talked about the trauma patient that has that, vasoconstriction. They're trying to shunt. They're trying to perfuse their organs. And so, giving a paralytic in that situation, if they're already hypotensive, they're decompensating, may not be the best option. Again, patients, you don't want to give them any medications that we don't need to give them. And if we can keep their sedation and their pain to a level that's manageable with Versed and fentanyl, where they're comfortable, you're able to manage them well on the ventilator, then we should be going that route instead of just giving them a paralytic. Again, they need to be assessed when you get to the trauma center or to the receiving facility, and giving them a long-acting paralytic is not going to allow the receiving physician to do that. When we talk about Versed, our Versed is midazolam. It's an excellent medication. Again, it can cause some hypotension, and you are going to maybe lose a little bit of sympathetic tone with it. It's excellent though. We can give a dose range of anywhere from 1 to 5 milligrams, and I tend to go post-sedation management wise 2.5 milligrams at a time. And so I'll give 2.5 milligrams. Obviously if the patient's hemodynamically stable. If they're not, I may go a little bit lower of a dose, maybe go a milligram, see how they do. You can always give the patient a 500 cc fluid challenge, regardless of what the problem is. Even if they're a CHF patient, vascularly they're probably dry, and giving them a fluid challenge, even though maybe their lungs are filled up, is an appropriate treatment. So, give them some fluid, and try to counteract some of that sympathetic tone loss. So you're going to give that Versed every 10 minutes or so. Watch the patient, put them on the ventilator, and you can see if they're overbreathing the ventilator. And we'll talk about that. I'm going to do a podcast on ventilator management. We'll do a 3-part series on that, and I'll talk exclusively on sedation and how it affects the patient as it relates to ventilator management. So you've given your you've given Versed, and now we need to give some type of pain management. Like we talked about in the beginning, we need to give them an opportunity to relax, and being intubated, having that AT tube in the back of their throat is extremely painful. So we want to be giving them pain management on a consistent basis. Every 5 to 10 minutes, give them 50 to 100 micrograms of fentanyl. Really get them loaded up. Again, fentanyl is extremely stable on the blood pressure. It does cause a little bit of a histamine release. So you can have some bronchodilation, which is going to help them. You can have a little bit of vasodilation, but again, it's very stable. I've been very happy with it in trauma patients that have been hypotensive. You still give a small dose of 25 to 50 mics and see how they do with that. But we need to be doing that every 10 minutes. So if you give fentanyl and you give Versed every 10 minutes and you're doing this and you're really taking care of your patient's sedation, your patient's going to do better. They're going to be relaxed, or their oxygen demand is going to be lower, and they're going to be much happier. All right, so we've talked about all the pharmacology as it relates to RSI, and I may have missed a few medications, but these are the standard drugs that you're going to see in most protocols that I've worked under. We could talk a little bit about Valium and Ativan, but same idea. They're both benzodiazepines. They're going to be pretty similar to what Versed does. I know diazepam and lorazepam have a longer onset time than Versed, and they're longer acting. So they may be a little bit more beneficial post-intubation for sedation. That there is that argument, but I have found industry-wide that Versed is kind of the go-to medication. So I want to thank you for joining me on this. We'll come back for podcast number 2 on RSI. We'll go through the whole procedure. We'll kind of put everything together. We'll add the medications. I'll recap those medications in the procedure and go through everything. So thank you so much for joining me, and we look forward to hearing your ideas. Please email me with anything you like, don't like. I'm doing this all for everybody, for you guys. So, any ideas to make this better would be welcome. My email is eric@flightbridgeed.com, and I'll talk to you guys soon. Thank you.